then get started.
Okay, thank you. We ready now, Ryan?
We are, yeah.
Yeah, okay. Hi everyone, good afternoon and a warm welcome to this afternoon's PCC committee, and a warm welcome to everyone that is watching us live. We're being live streamed at the moment. I have apologies from some people, so if I read the list of apologies, please, Michelle. The first one is from Phil Metham, from Sharon Stolt, Dr. Paula Evans, Dr. Tim Maycock, and our Health Watch colleagues. Our colleague Simon Bell will be joining us later, as will Dr. Andrew Mariarty. And if we welcome Hannah Taylor, who's our team administrator, and this is part of her induction. So warm welcome to you.
Julie, we've got apologies from Gary Young as well.
Oh yeah, okay, yeah. Apologies from Gary Young, and I know Fiona will be leaving us earlier than we anticipated as well. They have a huge piece of work to go away and do for us. Right then, if we go first of all to the declarations of interest, and if I just check and have confirmation that these are no different to the ones that we've already got logged, and if anything comes.
That's somewhat unhelpful. We've lost our chair.
Yeah. What's happened to Julie?
Well, the screen just went black. Presumably she's trying to dial in again.
Well, let's just give it a few minutes and see what happens. Let's perhaps the electricity's gone off or something. Oh, needs another 50p in the meter.
Fiona, Julie says, could you start the social prescribing, please?
Yes, happy to. That's absolutely fine. Afternoon all. I said that I would bring to this meeting a review of the social prescribing link worker service that is running across our GP practices in the Vale of York. And colleagues will remember some months ago, York CVS tabled a report to outline how that was working in the city. So this is the parallel piece of work for the Vale part of our patch. Just as a little bit of a reminder that the localities that are covered in the Vale are Tadcaster and rural Selby, Selby Town and South Hambleton and Rydale. So this is a report on behalf of those three primary care networks. And the Model Commission for Social Prescribing started, certainly from a primary care network point of view, with the new primary care network contract about 2 years ago. And one of the many additional roles that practices are encouraged to embrace and employ has been that of the social prescribing link workers. So across the Vale, we have 7 social prescribing link workers, 1 in Tadcaster and rural, 4 across Selby, and 2 working across the patch of South Hambleton and Rydale. And the real focus of those roles is to be community connectors, if you like, working with patients and individuals referred to them, to offer a non-clinical support network for things that people might want to look at that are around their wider health and wellbeing needs. So whilst a significant number of patients are referred to them through the GP practice and from GPs and nurses and other clinical colleagues, anybody can self-refer to their local social prescriber. And in the Vale, those social prescribers are based in the GP practices, but they take referrals from across the wide bit of their patch. What's really interesting about the post is the fact that these roles have time to spend with people. They can have multiple visits with people, but they work with the individuals referred to them to build a support package that is unique to that person and is built around all of the health and wellbeing needs that that person might have. So rather than just looking at a particular medical condition, they're looking at all of their health and wellbeing needs and linking them into appropriate services. So it's a real opportunity for us to offer an extra level of support for our primary care communities, and also link people into services that perhaps are not as well known by the GPs because they link really closely into the voluntary sector. So I really hope you've read the report, and I hope you've enjoyed reading it as much as we enjoyed pulling it together, because it is such a fabulous success story across the city and the Vale. With our 7 social prescribers, they are seeing between 700 and 800 contacts a month, and these contacts often then don't need to see the GP because it isn't a clinical issue that needs sorting. It might be support with housing, it might be financial advice, it might be linking into clubs and societies to help people feel more connected into their communities. It can be around accessing physical activity or healthy eating sessions. So the range is absolutely endless, and you've got some really great examples in the report of the range of agencies that colleagues are linking into. I think what's really key to flag is just how important the social prescribing link workers are in that bigger primary care team that has been developing over the last 2 years. So as well as working really closely with clinical colleagues, they work really closely with our care coordinators, with our physios, with our mental health workers. So they're part of a really strong enhanced team that wraps around the GP but offers a different type of support for patients who might be referred. Throughout the report, you'll have seen lots of lovely patient stories, because I think that is probably the most valuable bit about understanding the impact that these services have. And it's really, I think, humbling to see the difference that having that continuity of support and that link into wider services is really powerful for people. So in the red boxes, you've got all sorts of patient comments and contacts that just says what a massive difference these roles have made. And you've also got some really great examples of the difference it makes to the wider system. So they link really closely with the voluntary sector, as I've already mentioned, but also some great testimonials from colleagues in social care, from our district councils and from some of our wider health partners as well. So I've mentioned the contacts, and I think if you imagine those 7 individuals having that really focused support with those hundreds and hundreds of patients that they're seeing, then you can really start to see how that impact is being welcomed and embraced by wider primary care. So I'm going to take it that people have read these and seen some of the reports. I think the key bit for me is how we build on this and build on this success. So one of the benefits, I guess, of these roles is, as well as spotting where we might need even more support in the community, our social prescribers are starting to identify where we might have gaps, and that's starting to be really powerful, because it means we can work with our social care colleagues and also with our primary care networks to look at where might we need to put funding into places that we wouldn't normally have considered contracting with, but actually there's a lot of support networks out there that we think we can work more closely with, and we can start to think about funding and having more sustainable options that are outside of health. So I'm going to leave it there, because I think the report is really self-explanatory, but we're really happy to take questions or any comments that people have. But I hope you'll agree that the impact that we've described in the report is a really positive story for how primary care are working with wider partners.
Thank you, Fiona. Steph, over to you, please.
What context, Julie? Just to say how brilliant the report was. I mean, it is heartwarming, isn't it? And I think Fiona does well to talk about it being humbling. Early in the pandemic, we reflected on the work of that single point of access, the SPA model that was engaging with people who perhaps didn't need a medical contact, but needed that point that was around making sure that loneliness didn't then actually deteriorate into a health issue. But when you then add the additional aspects of rurality to the Vale, really good, and a really good read. Thank you, Fiona, and I know you put thanks into the end of the report, but I would echo my thanks to that. Really sort of high spot in what might be quite a difficult meeting, actually, when we report on all the challenges.
Sean.
I was just going to ask Fiona, are there any plans to scale up the provision around these social prescribing link workers if they're having that sounds as though they are having a really good effect on, helping patients and practices to manage their workload? So are practices looking at actually scaling up that provision, do we know?
Yes, they certainly are in the Vale. So the social prescribing link workers were one of 3 very early roles that practices were allowed to employ under the primary care contract. There's probably now around 12 or 13 roles that they can choose from, but social prescribing link workers remain really central to their plans to support, because we know that actually a huge number of contacts in primary care happen because actually people don't know where else to go, and actually there's a significant number of those that don't particularly need a clinical response, but they do need help and support to be signposted to other areas that can give them that help. So yeah, social prescribing is definitely not going to go away in the Vale. They are massively well received, and they're really seen as a key part of the team. So yes, through the additional roles, there are plans to have more of them. I think probably what's going to change slightly over the coming year is we now have social prescribers, we have care coordinator roles, there's an opportunity to have health and wellbeing coaches, and actually they're all very similar. They're all roles that have slightly different nuances, but they're all based around looking at the health and wellbeing needs of that whole person rather than just one particular issue. So I think if anything, we might see a little bit more fluidity between the different support roles that are part of that primary care team, but that approach of working with the voluntary sector, working with our social care partners is absolutely front and centre of a really sustainable primary care. And you can see from the stories that patients and families, actually the impact on families is quite significant for people who take up the opportunity to get that support. So yeah, I'm really pleased that these are going to keep growing and that we will have more and more of them. And what we would like to see is some more creative commissioning, I think, for some of these roles around how the voluntary sector might help enhance some of this and look at where else that social prescribing skill set can come from. But yeah, they're really critical, and we've definitely got plans to have more of them across the patch.
Yeah, so I think what we've just heard Fiona describe really well is we get used to the language of primary care, and some people perhaps still think of primary care being only about a GP. And actually there's a wealth of people who can help you with your well-being. So it's just, if we continue to sort of explain and explore those different roles that you might be offered when you contact your general practice, when you ring for the surgery, one of the reasons why receptionists may ask you a few more questions is that they are finding the right way and the right person to navigate you to, who can give you the quickest response to your issue, which invariably in modern general practice isn't always the GP.
Thank you,
Yes,
Steph.
thanks,
I think
Steph.
that's an invaluable message, isn't it, Fiona?
It is. No, that's really helpful, Steph. Thank you for reiterating that. It's having staff that are part of that wider team that perhaps have longer to work with you to understand what matters to you than perhaps the normal traditional GP appointment allows. And actually, most of my GP colleagues would admit the social prescribers know far more about what's out there that can help and support people than they do with their very clinical lens. So that's why having all of those members in the team is absolutely critical. And you're right, we're working really hard around our communications to help patients understand the value of these wider roles and actually the added richness that brings to the wider primary care team. And hopefully the more we can publicise some of these success stories, the more familiar that will become for our communities.
I mean, we talk about multidisciplinary teams, and this is what, you know, this is the skill set that we've got in a multidisciplinary team, and I think it's absolutely invaluable. To me, it was heartwarming to read the report, and it's the personal stories and then the knock-on effect. David.
Yeah, sorry, I can't find the mechanism to do it remotely, raise a hand or whatever, but there we go. Yeah, no, I mean, yeah, absolutely, you know, and as Fiona knows, you know, I'm very well supportive of this issue. I mean, as I always do, I have to say, I always like to see a what doesn't work in reports, and it does run the risk of being congratulatory. Right? I mean, I know it does have recommendations for the future and so on, but I do know from other experiences that it doesn't always work, and that some GPs can be reluctant to use social prescribers because, first of all, they don't like the name, and you know, so it's not always straightforward. So for me, you know, it would be a little more useful if there were some things that didn't work or some things that that you need to concentrate more on. But having said that, I think it's a fantastic scheme, and what an investment for us, really. As long as we've got the capacity to manage it, because the more successful you become, the more management it needs. But well done, really good scheme.
Yeah, thank you. And I guess just picking up on that, David, it's a really good point. I think our ongoing challenge, not just for these posts, but as we encourage primary care to embrace the wider roles that can add value to their practices, estates, and you know, how we make sure that all of these roles are well supported, because actually the role of primary care networks is to focus on the needs of their populations. So whilst these roles are linked to practices, they are working across a wide geographical footprint, and that's important because it means they can focus on areas where the need is greatest. But in having that really flexible approach, it's quite difficult to make sure that the workers feel part of a team. It's easier to feel part of a team if you're sat with the same people every day. The challenge of these roles is focusing on the areas where the need is greatest, and that sometimes means you're working with many different teams, and keeping those relationships strong and making sure that our workforce feels supported is sometimes harder. But the more these additional roles grow with that wider workforce of physiotherapists and mental health workers and care coordinators, the more that support network is there. And Heather Wilson, who did a huge amount of work on this report, so thank you, Heather, she has done an amazing job of pulling together a Vale network for all of the roles across our patch that have that kind of care coordination type role. So now the social prescribers across the patches are meeting regularly, sharing examples of good practice, sharing what works, and that's just another layer of making sure that not just our patients feel supported, but our workforce does as well. And I think longer term, our bigger gap is, as we see more and more success from these social prescribing type roles, how do we make sure that there is resource in the system to fund the voluntary sector to keep providing the support that we're signposting people into? Because actually the success of social prescribing is only as strong as the organisations and the groups that we have around us to be able to refer people into. So I think our biggest long-term risk is how we make sure that funding flows into the wider sector and perhaps away from some of the more traditional sources that we might have funded. I think that's probably the biggest challenge.
I think that links into what David said. We always need the worry bit, the downside bit, and for me that would always be the downside bit, because it's okay us signposting people, but if we overwhelm them and they haven't got capacity,
agree.
How do we look after the voluntary sector and give them the same compassion and funding to be able to deliver the jobs that they deliver beautifully out there for our community? So yeah, fabulous report, lovely to read, and I think it's watch that space as this methodology moves on into other areas across the whole of the ICS. So thank you very much, Fiona. Steph, if we go over to you next, if that's okay. Apologies to anybody who has an agenda. We have colleagues that are stepping in for other colleagues. to be at other meetings. So unfortunately, Fiona has to leave us at this point, but Steph's going to take over.
So I'm going to pick up the item on the general update on our primary care network. So that would normally be an item that Gary Young and Fiona Bell-Morritt would speak to, but the big piece of work that's happening across primary care networks is to respond to the government requirement around looking at activity that can be put in place to respond to what we know will be a very difficult winter. Colleagues have heard us talk about how much more demand there is in the system for those services that are out of hospital and in hospital. So the primary care networks are working on a very speedy turnaround to look at what services can be implemented that might help support some of the impact of winter. So they'll necessarily look at things that mean that practices can work together a bit more, look at different ways in which we might be able to respond to the range of respiratory illnesses. We've got colleagues in the PCNs and the CCG working on how we might use more working together to triage same-day urgent care activity. So that's really the sort of the work of the PCNs. Obviously underpinning that, our practices continue to be both extremely busy responding to demand, but also responding to that demand with varying degrees of impacted workforce. So particularly with staff isolating, where they've got family members, they can continue working, but working remotely. But we do see staff illness also, because we necessarily have a very fatigued workforce who have been flat out. PCNs are also the mainstay of delivering our vaccination service, which has had such an impact on protecting our vulnerable citizens. So as well as normal everyday responding to same day urgent need, routine work, they're also delivering on the whole the vast majority of our vaccination program. And when we talk about primary care in the vaccination context, we've got some community pharmacies also supporting us with that. So I have a sense that Gary and Fiona would have gone into a lot of detail, but the headline is, as in addition to the demand of normal general practice, our primary care networks are now responding to the government request that we are imaginative in creating more capacity to respond to what we know will be a very difficult winter.
Thank you, Steph. Have we questions or comments, please? Oh, I can't see anyone on the screen. Everyone seems to have the cameras on. No, it looks like, oh, Bill, have you no? Okay, sorry about that. Our technology is really trying us this afternoon. Thank you, Steph. Thank you for stepping in at last minute, and I'm sure that you did our colleagues justice. What I'm going to do is step back a little bit, because those of you who noticed my seamless disappearance from the beginning of the meeting will have noticed that we didn't take a look at the minutes of the last meeting. And what we needed to do is just to agree that they're a true and accurate record. Yep. Thank you everyone. And if we look at the matters arising, we've actually picked them up, and we will pick them up as we go through the meeting. Okay, thank you. I'll see who we're going to juggle next. Sean, it's over to you, please.
So would you like me to do the risk register next, Julie?
Yes, please.
Yep. Okay, so I'll give you a quick run through of the Primary Care Commissioning Committee risk register, which we bring to each of these meetings, just to highlight the key risks that this committee needs to be cited on. So I think, first of all, I'll just explain that we've removed the risk which was previously in this report around the learning disability health checks, because of the increased performance against that target, and the practices are now doing really well in terms of delivering those learning disability health checks to patients to the extent where it's no longer a risk that we need to manage. That's happening quite well across all of the practices in Vale of York, so that's a good news story. We still, however, need to keep the serious mental illness health checks on the risk register. I think although there are pockets of real progress across the patch with these SMI health checks, particularly to give credit to South Hamilton and Richmondshire, Rydale, PCN, their credit, they've now got 75% of people on their SMI registers have received all of those health checks. Selby Town are doing very well as well, but there is some variation. So we just need to work with those PCNs just to ensure that we try and progress with those checks as best we can. So we'll leave that on the risk register and report back. The second risk we have is around access to general practice and reputational damage. Now, as Steph has just described, there's a huge amount of work going on at the moment in general practice around improving access over the winter months to appointments and trying to increase the capacity in general practice to meet patient demand. I've given a little bit of data there from NHS Digital, which shows our overall appointment numbers. So you can see that we have recovered since the start of the pandemic, and our overall appointment numbers, according to this data, which does have some caveats, are broadly back to where we were post-pandemic. But having said that, there's a lot of work going on around the Winter Access Fund at the moment in terms of increasing those appointment numbers further for patients. So we will be working closely with the PCNs, with NHS England, regional colleagues over the next 4 months, taking us to the end of March, to try and provide as much capacity as we can for patients over that winter period. There are some issues with the data that we're working on as well, just to mention that the data has some caveats, I suppose. And we are aware that a lot of our practices are actually using access management systems alongside their clinical systems now, which help them to effectively triage patients and get them signposted to the right clinician very quickly. But some of those contacts probably aren't being counted through the national recording system. So we're doing some work with the data quality alongside that program to introduce additional appointments into general practice. So we'll update on that as we move through the winter months. And then the last item is general practice wellbeing, which, although it's not been updated, I think we could all agree that the general practice workforce is increasingly stretched still. And as Steph has just explained as well, they're largely responsible for delivering all of the vaccination program over the past, it's coming up to 12 months now since the vaccination program started. There's a real challenge around increasing that capacity over the winter months. And staff, I think we recognise, are tired. They're still being exposed to the risk of COVID. and we know that staff are still having to take sick leave and self-isolate. So there is something about just keeping an eye on that general practice well-being piece, because without our workforce, we can't deliver those services, which is really important to recognise, I think. And we do continue to work with the local medical committee and, you know, work with practices to understand how their staff are coping and if there's anything we can do to support in that respect. So that concludes that piece, unless there are any further questions.
Sean, when we considered particularly the wellbeing item, we were particularly concerned about the more senior members of GP practices and the extent to which they could access wellbeing-based services. Is there anything being brought forward on things like mutual aid, which was one of the things we certainly did sit with senior individuals in policing, where we had personal challenges to overcome?
I think it's fair to say that the LMC kind of pick up that agenda with the senior partners in general practice and provide that more kind of well-being and mentorship type support. And to all credit to the LMC, I think they've done a lot of work around this in terms of supporting the workforce. I think alongside that, part of our plan around that winter capacity program is to enable practices to give each other mutual aid. So if the system works, hopefully that pressure on those senior clinicians who admittedly do take the brunt of all this and tend to be the ones that are doing the really long hours and picking up the admin work, you know, on an evening just to keep the practice running. If we can get the practices working together to deliver that resilience and business continuity and mutual support, I think that's what we're trying to get to, that they can support each other when, you know, one week of practice could be doing really well. The next week it could have 5 people off with COVID and find it really difficult. And that applies to the admin and management staff as well. So I think we are trying to help practices to provide that mutual support to each other, not only just on a clinical basis, but on the management and admin, because without that function, the practice can't deliver.
Thanks, Sean. Thank you.
And just to reassure you further, Phil, the decompression sessions that we commissioned, we have a report, but it will come in the future. So that is another outlet to enable our GP colleagues to be able to access. And I think the primary thing was that for them was the confidence away from their peers. So it protects their dignity, which is really, really important. But we continue to look at ways of supporting our colleagues. It's absolutely our primary thought at this moment in time, especially when you think how they've stepped up for us and exactly the pressures that they're under. Okay, any more questions or comments, please? Okay, welcome, Simon. So if I go back again in the agenda, and I welcome Simon, our Chief Financial Officer, and if he can update us on our financial update. It's a verbal one, and he'll explain why.
Thanks, Julie. Yeah, it is verbal only this month. That's because the planning timetable and the subsequent publication of allocations has been quite late into this second half of the financial year. So we only received confirmation of our allocations yesterday. They were in line with our annual, our submitted draft plan, which the governing body has approved. So that's good news. So just a verbal update on month 7 at this point. So we'll bring a month 8 report back in due course. But broadly speaking, all continues as planned. We still expect to break even as a CCG for the end of the year. Within primary care specifically, prescribing continues to be a cost pressure, which we're working on. We have now received confirmation of winter access funding for primary care in the order of £1.1 million. And I know Steph and Sean will be working with primary care to deploy that as fast as we can to make sure people can make best use of it over the winter period. Probably not much more to say on the month 7 position at this point, Julie, but happy to have some questions or have a wider conversation.
Thank you, Simon. Just to reassure everyone that this was actually discussed at Finance and Performance in great deal detail this morning. But if we've got any more questions or comments, I'm happy to take those. Thank you, Simon, and again, thank you and your team. I know it's difficult. Often the deadlines don't marry up exactly as we wish them to, and yet your team just embrace whatever is thrown at them and continue to be consummate professionals, as do the rest of our colleagues. So thank you. Right, Steph, we're juggling again. I gave you a little bit of a breather in between because I thought you might need to take a little breath. But if I can get you to take now, it's item 7, and it's the COVID update, please.
So I'm going to start by sharing my screen and sharing 2 slides that have been produced by York Council colleagues in their public health team, and they presented this at the Outbreak Management Advisory Committee yesterday. That's also a public forum, so if people want more information about what the city's doing in response to monitoring the outbreak, then that's the place to join us at. So this overview shows where York is in terms of the official validated rates of COVID cases in York per 100,000, and they are 445.9 per 100,000 population. And you will see on the left in red where we are in the region, and on the right you will see that our red line is York, and we're currently above both the regional and the England average. So that's indicating to us that our case rates are high, and certainly higher than we've seen for a little while. When you look at where the cases of infection are, they are in our younger age bands, and that's not unsurprising when you think about the vaccination program. So we're seeing our younger age children, that 5 to 9, and then 10 to 14, and York have done some additional work that identifies that it is those younger children who are the point of infection, and then they transmit that infection to other people in the household. Now, if we think then about specifically our workforce, we are now seeing that that continued rolling in of children being identified as infected, and then parents and household members then needing to isolate. So now one of the obvious good things that we're doing in the city is the successful vaccination program, because that's doing 2 things. One, it is mitigating the impact of infection on our most vulnerable, and it is also then reducing admission into hospital. So if I just go on generally about the vaccination campaign, we go through different phases of the vaccination campaign, and our eligible population in the Vale of York on the whole, we're looking at vaccination rates for first and second doses in that 80% range, and we're now including our 12 to 15-year-olds. So previously you've heard me talk about vaccination rates for first and second doses in the high 80s, but we've got this additional group of new eligible 12 to 15-year-olds now. We're doing the universal offer, and we're at the 78%, and of that 77% have been boosted, have had their booster dose, and that's really good because we are seeing a lot of enthusiasm. And maybe that might be over egging the pudding, enthusiasm, but there is a good take up of the booster jab when people are eligible. So just to remind everybody that you're eligible predominantly for your third booster dose 180 days after your second dose. Now, there's been a change in that you can book your appointment a month before that, so that helps with our planning. I would encourage people. Our vaccination services are still available to offer you your first and your second dose. So please, if anybody's listening to this broadcast live or later, I would urge you to engage with the vaccination program, and we can offer you your first and your second doses. Our care home program is really working and delivering excellent results. As at the 23rd of November, we got 97% first and second dose uptake, with 84% of those residents in a care home had received their booster dose as well. So full protection, first, second, and their booster dose. And the staff vaccination rates are for first doses, second doses are almost at 100%. In the city of York, we haven't seen a significant number of staff leaving the profession due to a mandated requirement to have COVID vaccination. Boosters are some way behind that at 40%, but if you just sort of reflect back, you only become eligible for your booster 6 months after your second dose. So we had a big push to get those second doses, which were slightly behind. So some of those staff just aren't eligible because they're in a younger cohort, and the booster doses are working through the eligibility and are now for our over 40s. So if your timing is right and you're over 40, then you'll be offered your booster, and that's really just to plan our supply. So in the city of York, we've still got some ward areas with low uptake, around 60 to 65%, depending on whether you're counting first doses or second doses. So we continue to work with our practices and work with our local authority teams with their contact tracers to try and think through what could we do differently. But again, people will have heard me say this is a voluntary vaccination program, so we always have to get the balance right between not harassing our citizens. But one of the pieces of work that we have been doing and working with our partners, particularly our hospital partners, our midwifery services, is to be offering vaccination in antenatal clinics. One of the lowest vaccinated groups in the country is pregnant women, so we've been working on how we can improve the vaccination uptake for that cohort, and that's that's a work in progress, but when we have more time to engage on a one-to-one basis with people to make sure that we can have that really detailed conversation with them about the pros and the cons and get over the misinformation, then we are seeing a greater uptick in the vaccination of that group. I want to end by actually talking about the flu vaccination program. So just to remind people that we started our flu vaccination program in September. Very good take up to the extent where supplies were all used up, and we just needed to wait for supplies to come back through. We're reporting at early November that 65% of our eligible cohorts had taken up that flu vaccine. But we have got some reporting issues with the two systems that we're reporting, so we're going to just do a bit more work on that. But again, the over 50s, we just need to get those messages out about eligible cohorts who can get their flu vaccine for free, and it's really important that people consider both their COVID vaccination and their flu vaccination. I did say I was going to end there, but something's just come to the forefront of my mind, mainly because I just heard the postman deliver my lateral flow tests. So at home testing, really good practice as we start to move into the holiday period where there are bigger groups of people coming together in indoor settings. Really good practice to continue to test yourself and really be keen on making sure that those infection prevention control measures are in place, that there is good hand hygiene. Don't forget the basics, that you are wearing a mask indoors, and that you're thinking about ventilation as well. So yeah, let's all keep well, respect our colleagues and our peers, and stay safe as we move into the holiday period and bigger groups coming together. Thanks, Julie.
Thank you, Steph. Yeah, it is about respecting each other, isn't it? It's good to see the figures for the take-up of both vaccines, and I think it's important we that we continue to be vigilant and thinking about it is our responsibility. I know Sharon was here, she'd be saying hand washing, mask wearing, social distancing still, and we still need to be very mindful of other people. I think my concerns are the little ones in school, our little super spreaders that like to hug, will play, will, share the same equipment, will share sweeties, and again, I suppose that's down to the same rules, isn't it? In school, they're still adhering to hand washing and, as far as they can, social distancing, but children have to grow and thrive, which is
Nimbus Care are now supporting and supplementing the Universal School Program. So they're supporting the school immunisation teams, and we anticipate all our schools to have been had a service for vaccination by the end of November. But it's just worthwhile. Our guidance changes all the time. So if I was speaking to you last week, we'd have been saying, but just be mindful, if you have a COVID infection, you won't be offered your vaccination until you're 4 weeks clear of the infection. There is now a view that younger people actually need to wait 12 weeks. So we will be doing mop-up sessions, but when we talk about going into schools to do the vaccination program, if you recall, it's a similar sort of message that we did about the numbers in care homes. If there's an active infection, we need to risk assess, not going in and becoming part of the spreading regime, but also not offering a vaccine to somebody that's not clear of the illness. So there will be a mop-up session in that school, in that universal school age offer, but our numbers will play a bit of catch up pre and post Christmas as we just sort of plan and organise around active infections.
Thank you, Steph. Any more questions or comments? Okay, thank you. Thank you, Steph. That's invaluable. It really is. If we're over to Carl, I see Carl's joined us. So if we can welcome him and his presentations around the disability learning health checks.
Afternoon, everyone. Thanks for having me. For people that don't know me, I'm Carl Donberband, Programme Lead for Mental Health and Complex Care at the CCG, Vale CCG. So yeah, I just wanted to share, really, it's just for information and an update really on the personalised care transformation monies that we were able to bid for from Humber Coast and Vale. Well, Humber Coast and Vale held that money, which we have used in the Vale of York to help target improving the quality and personalised care offer for people receiving an annual health check if they have a learning disability. And just some of the background of this is all people with a learning disability are eligible for a free annual health check in primary care with their general practice. So really important to help identify any unmet health needs or detect potentially some minor, but as well potentially life-threatening conditions. So really important that people receive these, and we've been doing a lot of work to promote these in general practice and with primary care networks. And just to, before I go into the detail of this, we introduced this scheme to offer more personalised healthcare checks. The Vale of York overall position with learning disability annual health checks has increased significantly, and at the end of last year we achieved the long-term plan, the NHS long-term plan target 2 years earlier than the target was. So really good achievement across primary care. We did an extra 324 health checks compared to the previous financial year, which during COVID is really fantastic achievement. So this was about really going further then with the health check to offer it in a more personalised approach. So it's all about improving the quality of the check. We were able to bid from, there was a small amount of money, well, some money for Humber Coast and Vale as invited CCGs to bid for. So myself supporting the primary care networks across the Vale of York, we developed bids, and every PCN developed their own project brief and bid. They all really along the same lines bidded to increase the personalised offer with health checks, which included things like having a more coordinated approach to the health check, increasing referrals to social prescriber link workers, and developing a much more personalised approach. For example, more in depth around the reasonable adjustment, understanding people's reasonable adjustment requirements, and having a really personalised action plan following the health check to make sure that the plan was delivered to meet their health and well-being needs. So since then, we've developed contracts with each PCN. Like I say, everyone has signed up to them. We have had feedback from Primary Medical Group in particular at an event in York where they shared an update on the progress they were making and doing some really innovative work. We're really pooling a lot of the resource that's available around improving annual health checks, to employ things like care coordinators, increase capacity with social prescriber link workers, to bring together an MDT approach really to supporting people after the health check, to help them access wider community support that could help them overcome any like health needs, for example, access to weight management support and things like that. So the intention of this really is a learning process as well. So within the contracts, there's an expectation then for the PCN, the primary care networks, to share any learning that they've had from this, understand potentially any barriers in the system, but also celebrate the really good work that they're doing across the wider Humber Coast and Vale footprint, to potentially use further personalised care transformation money in the future to roll out across a much wider footprint. So the expectation is that primary care networks will update that by March 2022. Just in terms of the overall annual health check performance so far this year, overall the Vale of York CCG is on track to deliver the 75% target. We exceeded it last year, so I'd expect it would happen again this year. However, just to note, we've also, our register size is increasing significantly as well. So more people are being added to the register, which means more people are getting a check and will be eligible for one, which is fantastic. So I think that summarises it all really. Just please ask if there's any questions or anything further you want to ask.
Thank you, Carl. That actually links in. Unfortunately, you weren't here for the link worker stuff, but I think it gives us an overview of each project that we work on, links to others. So nobody really works in isolation, and it's absolutely invaluable. Apologies if anybody saw me looking at technology. We have colleagues that are joining the meeting later on, and somebody's struggling. So hopefully we'll get them to join us in a moment. But questions or comments to Carl? Steph?
It's really good stuff that you've been doing with Carl, with our practices, just to facilitate what they're already doing and then sharing the good practice. I just had a question about how we link this piece of work probably to some of the priorities that then emerge. So, for example, we know we're taking a much more population health focus. So in the York place, they've put as one of their significant priorities diabetes. And I just wondered how we're linking diabetes in what we might consider the whole of the population, and then any reasonable adjustments to make sure that we're linking in to a specific group of people as well.
Yeah, it's a really good point, Steph. And we are. So I'm a member of the York Population Health Management Hub. We've developed a plan on a page really for the York area around this, and I think we need to do something similar for the Vale. But one part of this is the annual health check, but obviously it's much wider than that. So it's understanding what the priorities are around that we need to address to tackle these health inequalities. I think you've seen in this paper that people on average with a learning disability die much younger than someone without a learning disability. So it's about closing that gap. Like I said, there has been really good progress, and what we've started to do at the York Health and Care Collaborative is really identify what the priorities should be around in terms of reducing them health inequalities. So we've drafted something that will go back to that group to be able to, I suppose, ratify, and I'm aware that the PCNs, particularly in the York area as well, have identified as improving or reducing health inequalities for people with learning disabilities as a key priority for them in terms of their other contracts and investment opportunities. So I think there's lots to do, and the other part is linking in with the York and North Yorkshire partnerships as well around learning disabilities. So we're linked into both of them. The York One's meeting again next week. So again, we'll be sharing a kind of, so that we have a real health and care approach, joint approach to supporting people with learning disabilities.
Thank you, Carl. And I think linking into our partners in North and North Yorks, it sort of makes it stronger for the future. And I think most of our colleagues sat here today are thinking about the future of people as well. David.
Yeah, just say a very good report, very clear, thank you. The mortality figures are frightening, aren't they? 23, year and so on. So, I mean, this really is one of those things where, a relatively small investment now must be saving the NHS quite a lot in years to come. So, it makes absolute sense, and let's get above the target.
Yeah, absolutely. And there's much more. There's a much bigger. This is just a small part of it, really, just to incentivise the personalised care approach to it. But in terms of the wider health inequalities and the annual health check contracts, enhanced services that we've been promoting with general practice, the income opportunity is much higher. But absolutely, the key priorities is that obviously we reduce that disparity between someone with learning disability and someone without. So I think there's been really good progress made, and I think it just shone a light really on it, the COVID, and in terms of them potentially widening the gap with health inequalities, but as well with locally with practices have done well in terms of the annual health check performance. So I think, yeah, good progress, but lots to do. So we need to keep this on the agenda, don't we, in terms of keeping it as a high priority, which I believe practices and PCNs are.
Yeah.
Thank you, Carl. Any more questions or comments? No. Yeah, always lots to do, Carl. But I think as long as we keep rising to the challenge and we continue to work towards improving the quality of people's lives, then we're on the right track, aren't we? Okay, thank you, Carl.
Thank you. Thanks, everyone. Bye.
Take care now. Bye. Okay, Sean, it's over to you, please.
Okay, thank you. So I would just take the committee through. Sorry, Julie.
May I just make a quick announcement here first, just to reassure those that are watching this, that this has actually been discussed. The next item, which is about Hemmingborough, the closure of the Hemmingborough practice, has been discussed in a pre-meet by the board. So if you think we're not discussing it in great detail, trust me, we have, but I'm sure that we will come up with questions and comments. If I leave Sean to update you now, sorry to interrupt, Sean.
No, thank you, Julie. And what I'll do is I'll just walk the committee through the key points of the report. And I think just before I start, I'm just going to explain that I'm hopefully looking at this from a number of different perspectives. There's the practice perspective in terms of its sustainability and safety that we need to consider. The parish council's challenge around, that desire to retain that local service, and they've put a huge amount of work into their report, which they submitted to us, which is much appreciated. The CCG has got a responsibility to look at the sort of contractual, the equality and the safety aspects of this proposal as well. And I think most importantly, we all have to understand the impact of this proposal on our patients, the patients that are affected in this particular area. So if we bear that in mind, hopefully I will cover off each of those areas as we walk through the paper. So just to give you a bit of background, it was back in May that Postingate Surgery first approached us with a proposal to close their Hemmingborough branch surgery. Now that surgery is about 5 miles away from their main site in Selby, and it serves the populations of Hemmingborough, Cliff and South Driffield, all of which are about about 5 or 6 miles away from the main town of Selby. And the site, which has got one consulting room, was generally open for about 17.25 hours per week pre-pandemic. And just to give you an idea of the numbers of patients affected, Postingate's registered population is about 18,000 patients, and around 2,000 of those patients live in that Hemmingbrough area. And the principal reason for Postingate's proposal is that the branch site is no longer fit for purpose, and we'll talk through some of the specific details later in this report. And as I've already said, thank you to Postingate for their very detailed report in terms of this proposal. Also, thank you to Hemmingbrough Parish Council for their report, and particularly the patient feedback which they've provided, which has been considered in the recommendations around this report. So, and just to note as well that we have now received as a CCG a formal application notice to close those branch premises in Hemmingbrough as per the national policy, which is detailed in the Primary Medical Care Policy and Guidance Manual. So just to explain, there is a process which is required when a contractor wishes to close any of its sites, and that process is described in the Primary Medical Care Policy and Guidance Manual. There's a link there to the guidance, and I've quoted a couple of the prevalent sections just so that we can look at those. The key requirements for a practice that wishes to close any of its sites or services is that it needs to consult with patients around the impact, and it needs to engage with local stakeholders around the potential impact on them as well. And the decision that we took as a CCG when this first came to our attention was that we advised the practice should undertake a 3-month consultation process because of the size, of the potential impact of the proposed closure. And the practice has gone ahead and conducted quite a diligent and detailed and significant patient engagement and local stakeholder engagement process. Some of that is detailed here in terms of patient surveys and letters and frequently asked questions type documentation which the practice produced. There's a more detailed schedule of all of the engagement activities in Appendix 1 of this report as well. So if I can just get into some of the detail around the Hemmingbrough branch itself, this is effectively a converted premises. The ground floor has got the GP premises, and there's a flattened bedsit on the first floor. And the access to that property is shared with the residential tenants, with the GP surgery basically being split into 2 by a staircase which goes to the first floor. So access to that building is shared with the tenants who live on the first floor above. And due to the sort of infection and prevention control requirements around COVID, the practice took the decision to close or stop running clinics in that setting when the pandemic started because of the risk of infection. The main reasons that the practice has approached us with in terms of that closure are that the Hemmingbrough branch is no longer fit for purpose, i.e. it's a converted property with shared access, and that their main surgery in Selby at Porthome Road provides a much safer and more compliant environment for staff and patients. There's a risk that the practice has highlighted around lone working for staff, issues around patient accessibility not being met by the Hemmingbrough site due to the sort of nature and layout of that building. There are infection prevention and control issues due to the fit out of that building, which is no longer compliant. There are concerns around medical emergencies and how they can be handled. Sorry, I've just I had an IT blip with my mouse. I'll just scroll back. Not sure what happened there. My mouse has had a bit of a wobble. Sorry, I'm back in. Medical emergencies can be handled much more safely in the main site. The practice isn't happy with the segregation of the clinical room and the waiting room by that shared access with the stairs. And I think there's a view from the surgery, the practice, that they'd like to consolidate their services on the main site in Selby. So over the years, I think the viability of that Hemmingbrough branch has been discussed with the partners, and it's come to the point where they've submitted that formal application to close. Now, in the report, you'll see some photographs of the site itself, and I think in some ways a picture paints 1,000 words with these, and I think it's quite evident to see that the main access to the site is not compliant in terms of DDA or wheelchair access. There are photos of the consulting room and some of the risks around infection and prevention and control there. And I think it's probably evident from the floor plan of the building as well that it would be quite difficult to refurbish or extend this particular premises. So there are constraints around the physical footprint. So just to give you a quick comparison with the facilities that are available at the main site, the main site has got 22 consulting rooms as opposed to 1, a much bigger patient waiting area which supports social distancing in the context of COVID, disabled access, a much more modern setting which is offering obviously a lot more in terms of appointment numbers. And the practice is also suggesting that it offers a much wider range of services on the main site and access to a wider number of health professionals, which can't be offered through the Hemmingbrough site itself. So Postingate has had some engagement with local stakeholders around premises. None of those which have really come to any fruition at this stage, but it's an important consideration possibly as we kind of take this conversation forward in terms of what the art of the possible might be. And certainly in terms of the standards around healthcare premises, I think looking at that, you know, we can say that it probably doesn't meet modern standards. However, there are probably options that we could consider in terms of moving this forward. But whenever we look at estates, options and appraisals, these things can take some time to work through. So it's just to note that if we were to go down that route, it wouldn't be an instantaneous solution to the current position. So the practice has conducted an equality impact assessment itself, quite a detailed piece of work, and it did identify that there are a number of protected character groups who would be adversely impacted through the closure of the Hemmingbrough site. And those are generally older age people, people with a disability, unpaid carers, people or families on a low income, and people with social isolation. I think most of which the predominant issue is access to services in Selby because of the poor transport links between Hemmingbrough and Selby. The main site at Selby obviously offers a much more kind of holistic range of services, but they're only useful to the patients in Hemmingbrough if they can access those. So throughout this, both the practice and the CCG have had regular contact with Hemmingbrough Parish Council, and some of the commentary that's been received from Hemmingbrough Parish Council has been really helpful. There are definitely a couple of legitimate concerns that have been raised by the Parish Council in terms of, you know, addressing the issues about this being a rural community and access to services, and also an issue around the bus service timetable through to Selby, which effectively there is a bus which runs out of Hemmingbrough in the morning and comes back at about 4 p.m. in the afternoon. So public transport really isn't helpful in this situation. So there are a number of recommendations which the parish council made to the CCG, which we duly note. And what I've tried to do is pick up on some of those issues that have been raised by the parish council, and I've included a number of patient comments relating to transport issues, mental health issues, age-related issues, which I hope help to frame this in the context of that sort of patient experience for those people who will no doubt have issues accessing services in Selby. Just to note that as part of this process as well, the CCG has also run its own equality, sustainability, finance impact assessment, and this has been taken to the patient quality experience committee as well in the CCG and considered in terms of the impact on patients. So I think just to summarize quickly the key findings: there's been significant engagement with patients and local stakeholders. The proposal has been independently assessed through the quality and nursing team. The CCG acknowledges and accepts Postlegate's position that the site is no longer fit for purpose. And it also recognises through extensive patient engagement that this site is a valued community resource in Hemmingbrough, and that the transport links into Selby are really quite poor. There is something about this not being unique. There are a lot of sites in North Yorkshire that don't have a branch site of their own, but there's no doubt that the proposed closure of this site would have a significant impact on a number of patients in Hemmingbrough. So the recommendation to the committee is that because of the risks that have been raised through the equality impact assessments around the suitability of the site, the recommendation is that the committee supports the proposal to close the branch based on its fitness for purpose, but acknowledging the value of the existing service to patients and the parish council's challenge around further exploration of options around premises, that we undertake an options appraisal and feasibility study to gain a bit more insight into possibilities around a potential new build or alternative accommodation. And also the third recommendation is that in view of the socio-economic dimension and health inequalities relating to some of the patients who would be affected, we do some work with Postlegate Surgery to ensure that we maintain those services to those vulnerable patients in this area as well. So I'll stop there and ask for any comments or questions. Phil?
Thank you. Well done, Sean. This is a cracking report. It belies, I know, an enormous amount of detailed work, not just in consulting with interested stakeholders and patients, but also in developing the original proposals anyway. My view is that it will be unsafe for us to continue to allow the practice to use their current premises. There can be no better time to think about that as we move into flu season and the time of year when patients are going to suffer from a lot of significant viruses other than COVID. But I do support also the other two recommendations, the third one in particular, about how do we bring the service to patients where the patients can't come to the service. So I think a rounded, mature, well-balanced report. I'm happy to support it. Thank you.
Thank you.
Thank you, Phil. Any more? David, thank you.
Yeah, very similar really, Chair. The premises are clearly not fit for purpose. You know, the open brickwork and the infection control and sharp stone floors and so on. And, you know, no entrance for people with any kind of disability really is not acceptable and it's not safe. And therefore we should do that. But however, the issues that are raised by the very comprehensive report, which I think is balanced and fair, and it's got the support of local people, even though they may not agree with the outcome. I think we do need to ensure that those people that are vulnerable in that community get as much support as possible, and that we should use our, our social prescribing outlink workers and whatever else to do that. I think we should remember that in rural communities, and I live in one, GP surgeries are very often 3, 4, 5, 10, 15 miles away. And, people have to make their own arrangements to do that, but people usually do with, and if people are in the very unfortunate position where they haven't got friends, neighbours or relatives that can help, well, we should step in and make some definite arrangements for that. But in principle, I think the decision not to continue the very limited service that there at the moment anyway is the right one. But it's not a decision that's been taken lightly, but it is the right decision.
Thank you, David, and you are right. It hasn't been taken lightly. We have discussed this at great length, not just earlier on today, not just briefly again now, but for quite some time since it was raised to us. And I would say that I would reiterate that we have, that we do have a facility that doesn't meet the needs of vulnerable people. It doesn't have the correct access or egress. It doesn't have doffing and donning places. It doesn't have an area where you could have that maybe safeguarding, caring, aside information with somebody who's maybe come with somebody who's poorly, so a carer or whatever. There are so many things that are missing in that environment, but wholeheartedly agree that we need to make sure that we're planning for the future, and that we haven't let anybody, not setting anybody to fail. Paula, apologies. Again, if you saw earlier on, I was distracted. We were trying to invite Paula, and our technology is batting against us today. So, Paula, we're just going through the recommendations and agreeing them. But if you want to add some richness to the report you gave us this morning, that would be very helpful.
Yeah, thank you. I do apologise for getting on a little bit later than anticipated. I think the report, it's sometimes in a report things can feel really dry, can't they? But in terms of me being brought into this to undertake the quality and impact assessment, which involved that tour around with the photographs involved of that environment. There was a number of things that really did strike in terms of the physical space that environment offers. And I think from a practical health and safety point of view, there are a number of things in terms of infection prevention and control that clearly the pandemic has heightened awareness of that, but actually pre-pandemic there are a number of aspects that clearly the facility isn't fit for purpose on, in terms of if, for example, if people were to vomit, have diarrhea, have other infections that potentially were you weren't aware of prior to coming in, it will be very hard to properly decontaminate that facility as it currently is. And if we're thinking about how we would manage any emergencies for people who are in there, then not least the environment in the clinic room, in terms of if somebody were to fake collapse, the physical environment doesn't lend itself to, one, being able to maintain that person's safety in terms of doing that, but also how you would manage an emergency in that situation as well. But also thinking about, I hear absolutely loud and clear the needs of people who are perhaps vulnerable, have access difficulties, perhaps are wheelchair users who might find travelling difficult. But in terms of reviewing the accommodation, it isn't accessible. The toilets, whilst there are 2 toilets there, neither of them are accessible via wheelchairs effectively. So it is a concern. And if we're thinking about how we meet the needs of people who do have carers who would be coming along with somebody who is poorly, we absolutely understand the impact of, say, carer strain on a family, and the ability to be able to use professional curiosity in terms of another member of staff to perhaps engage with the patient separately to the carer or the family member, loved one. That is really very limited and does flush out issues around how can we make sure that we're hearing 2 sides of that story, that we're hearing and gathering information that brings a whole picture in terms of that family, and also potential issues then in terms of how we ensure we're doing what we can around safeguarding as well. So how can we pick up on cues that perhaps we need to explore a little bit further that you can do in a better facility as well. So the aspects for me in terms of actually that physical building is that it isn't fit for purpose in modern day working, and how a GP would function with a chaperone, but essentially very lone working, means that actually it can be really unsustainable for the host practice to send out the appropriate clinician, because we wouldn't want a less experienced clinician going out and lone working, and can be very challenging currently and will be moving forward in terms of sustainability of certain professional groups. And I think the aspect of actually the facility is mainly providing the dispensary service for medicines and a GP clinic, but clearly isn't the host site of the full range of primary care that patients and members of the population can get access to through Postingate as well. So it's one aspect of primary care services that will be lost through Hemmingborough not reopening. So we've really got to be mindful of how we make sure that patients do get access to the full range of primary care services. That actually means that it's not just about a building as well. And yeah, absolutely not lost that I can completely imagine how people do like to see and feel that actually having access to something in their village is really, really valuable. But I think we have to think of it is just one aspect of primary care services that is provided out of that building. And it would be my view as a nurse that physical facility isn't able to work in a way that actually is compliant with current standards associated with healthcare, health and safety, and buildings regulations, etc. as well. So those were the main things that I wanted to pull through really on here. And yeah.
Thank you, Paula. Invaluable to me to get that compassionate nursing, experienced nurse perspective on our discussions today. So thank you very much. Simon.
Thanks, Julie. Let me just put my hand down. Yeah, so noting the further work required that Sean took us through, I just echo colleagues really. The facilities that currently isn't suitable for the practice.
I'm sorry, Simon, your sound isn't very good. I don't know whether anyone else is struggling.
Okay, any better?
That's brilliant, thank you.
Sorry, I was speaking too quietly. So noting the additional works that we have to carry out, as Sean took us through, I just echo what other colleagues said, which is the premises are just not suitable to undertake care as they are. So I'd support the recommendations in the report.
Thank you everyone. It has been invaluable, and I think it's hard. It's always hard to close a practice. None of us want to do that. None of us want to be part of anything to do that. But I believe strongly, and listening to all of the work that's been done in the background, that we've got the informed information that we need to make the right recommendations, and those were presented to us today. So thank you all. Okay, thank you. Moving on, Simon, it's back to you, and it's about the local enhanced safeguarding and the LES, please.
Yeah, so this is for the committee to approve in principle putting these services into a LES. We think this will make things easier for the CCG and also for practices in terms of administrative burden and our ability to check that safeguarding reports have been done, so the auditable side of things. GPs get requested to do safeguarding reports from a number of sources. We've had a process in place whereby we try and, on an individual basis, authorise those and pay for those, and that's a difficult burden for practices, as it is for the CCG, and these things are growing over time. So we've discussed across the CCG and at the exec team our recommendation that we move these into a locally enhanced service. We think the overall cost will be around about £70,000 a year, but it's difficult to be precise given that we can't exactly know what the take-up will be. And part of putting this into a LES is to make sure everybody has fair access to it, and so that we do know who's taking it up and who's not. So part of what the LES will help us achieve is a better view of where and how these things are taking place. That's probably it by way of briefing. It's set out clearly in the paper. It's just asking the committee's approval to move that on to its next phase, which will be the more detailed specification of the LES, which we'll work across primary care to jointly agree.
Thank you, Simon, and we're certainly seeing the figures for the increase coming through QPEC, and they seem to be rising dramatically. And when you think of the additional workload that our GPs have already got at this moment in time, it's about simplifying the paperwork. It's about joining the dots to ensure that they're paid appropriately, and identifying those that at this moment in time don't realise that actually it is their gift, that they actually earn this monies for the extra work that they do, because it is absolutely invaluable to have their input. Questions or comments for Simon? Yeah.
Chair, unlike the previous report, which required a lot of careful and detailed consideration, this one is easy to support. It benefits everybody involved. And, you know, when you read that the first and principal benefit is cutting down the workload and time involved in this for GPs and their practices, why on earth wouldn't you want to support? Happy to do so.
Thank you, Phil. Echo that completely. And from the nods on the screen, I would say that, Simon, yes, we'd all agree that we need to take this to the next stage and get all of the checks and balances sorted to move it on.
Thank you.
Thank you, everyone. And the next bit is back to you, Sean, please. And it's around the COVID laptops that the GPs currently have.
Yeah, so just to explain a bit of the background to this, if you remember, towards the start of the pandemic, general practice changed its working arrangements almost overnight. NHS England asked practices to adopt a total triage model where they spoke to patients on the telephone before deciding whether they sort of came into the practice and needed face-to-face appointments. And there was a really big shift nationally to working remotely. And as part of that remote working solution, there was some national funding made available to us to buy laptops for general practice. And we managed to buy 373 additional laptops, which we deployed to sort of PCNs and practices across the Vale of York, which have found, really good use. They've been put to really good use by practices to keep services running, to keep the business going, and services for patients running throughout the pandemic. So where we are now is that we have an additional 373 devices, which we effectively have to pay support costs for to our IT provider, Nex. Now that puts quite a significant cost pressure on the CCG in terms of how we fund that. And I think what we've tried to do is look at that in the context of the benefits that these devices are providing to general practice. So as I've kind of touched on, I think they've really helped practices with business continuity over the past sort of 12, 18 months. We know that staff have had to self-isolate either because they've become COVID positive or family members have. So these laptops enable them to keep working from home really effectively. There's also something about that flexible working and resilience where practices have been able to split their workforce to reduce the risk of infection and give staff a bit of choice and flexibility around how they work, whether it's from home or the practice. And I think there's something about it increasing capacity as well, because I know that, GPs will say that they take these laptops home on an evening and they catch up on all their admin work and they do extra hours. There's no doubt about that it's enabled some of the GPs and senior management staff in practices to do extra work in their own time. So with that in mind, we have a number of options in terms of how we fund the support costs for these devices. So one of them is just to ask practices to pay the support costs themselves. I think the risk there is that contractually, practices would legitimately say that their IT support costs should be covered through the GP-IT contract, which I'd agree with. And I don't think it's appropriate that we ask practices to pay for these in this instance. We did look at another piece of work around, with a view to bringing our IT estate back to its baseline numbers. So it would bring us back into that sort of baseline support cost. We could look at replacing some of the existing desktop machines in practices with these new laptops. So effectively, a laptop goes into an office and the desktop goes out for effectively recycling. The problem with that, I think, is that it would require a huge amount of resource, both from the CCG and practices, to understand how we could do that on a practice by practice basis. And a lot of practices are using their estate really flexibly at the moment and their consulting rooms. So it's not just a case of putting a laptop in a consulting room and the GP takes it home in an evening, because in any one week, a number of staff will be using that consulting room for a whole range of purposes. So I think we quickly realised the logistics of just putting a laptop in and expecting it to be shared amongst everybody who uses a particular room just wouldn't work. And in addition to that, I think the ask of practices to try and do that piece of work to understand which laptops go in instead of which desktops, it's just work that they haven't got capacity for at this time, I think. And the third option is whether the CCG could agree to fund those support costs, which come to approximately £86,000, which would take us to the end of the 2022-23 year. So the request to the committee, in the context of everything I've just kind of described around practice resilience and keeping services running for patients would be to agree to fund from the CCG budgets the support costs for these additional laptops going forward, if I can ask for consideration of that.
Andrew, can I put you on the spot here? I know you kindly, you've left one meeting and you've logged straight into ours. I wonder if you'd like to give us your point of view and let us know the positive impacts that the new laptops have had on your services.
Yeah, thanks, Julie. And thank you very much to Sean, who has really gone out of his way to engage with primary care on this, which it is an area of huge concern to primary care. The thought of functioning without this remote capacity now is kind of unthinkable, really. And obviously they were brought in for COVID reasons, and they provided that business continuity when there was possibly a more regular need for staff to self-isolate. But the part of it that I just really want to make sure that I get across, because I'm very keen to sort of speak up in favour of option 3, is the increased capacity, which you know, I know from, I can tell you from personal experience, but I can also tell you from the experience of all of my colleagues without exception, really, that extra work that Sean was talking about there on evenings, weekends, for example, say for GPs who are either off work that day or doing non-clinical work, to be able to jump on and help colleagues with that hugely increased workload at the moment has just been invaluable. And I think primary care would really benefit from the committee supporting that option. So I really appreciate you considering it. Thank you.
Thank you, Andrew. Simon, and then Phil, please.
Thanks, Julie. It's a tricky one, this, because strictly speaking, the CCG ceases to exist on the 31st of March. So I can't really make any firm commitments or binding commitments for and on behalf of the ICB. That said, I agree with all of the points made, that to try and do something different now, which we would need to do any of the other options, would not be something I support. So I think we do need to support practices to continue into next year. I don't think we've got an option available to us at the moment. But strictly speaking, I don't think we can recurrently commit the ICB to fund this, because we aren't the ICB, and as a CCG we won't exist. So I think it's probably a slightly more nuanced and or vague position from my perspective, that we need to think about. But clearly I wouldn't want to be doing anything now or making any statements now that would divert primary care away from its principal function at the minute, which is seeing patients.
Thank you, Simon. And I think we're going to see that more and more in decisions that we're trying to make for the future, and we're not sure what the future will be, because it will be the ICB. So yeah, it's a valuable comment. Thank you. Phil, over to you, please.
Thank you. Yeah, I'll pick up one or two of the points that Simon's just made. When you look at option 3, Sean, you record the fact that GPIT is some 60,000 underspend. Is that a recurrent underspend, or is it just for this year? Just for this year?
As I understand it, it's just for this year in terms of where that balance is this particular year. Yeah.
Okay. I mean, certainly my view would be that, like Simon, I think that the capability should be put into a program in the medium term, rather than just exploit the serendipity that we've got at the moment, that we've got an additional number of laptops that have been made available to GP practices. I wouldn't want those withdrawn from GP practices because of the additional flexibility and capability they give them. I might suggest, though, that we don't simply dismiss the replacement of desktops with laptops. It used to be the case that you had a desktop because it had inherently more processing power than could technically ever be built into a laptop. That's certainly not the case now. And as I've already said, particularly for a function like a GP practice, then a laptop surely is more suitable IT just because of the physical flexibility that it gives you. And you've already said to us that that's being exploited with people taking these home to take the practice home with them. So I think probably for me, a combination of certainly 3 I support, but don't dismiss out of hand, over time, the progressive replacement of desktops with laptops. Thanks.
Yeah, thank you.
Okay, any more questions or comments? Andrew?
Yeah, there's no argument with that at all, Phil. I think you're right. I think going forward, I'm sure that will be something that will happen. It will just naturally happen. And I suppose that at the moment, the position that we're in is that we're looking towards the end of March 2022, which is when the current funding will end. So, the concern is about having some continuity at that point. I think going forward, if there can be some option where laptops replace desktops in a truly functional way that accounts for the fact that there are different staff using different rooms, we've got the additional roles and all of this kind of thing. If all of those concerns can be addressed, I would be totally in support of something like that. But I don't think we're there yet in that respect. And I think that the slight worry we've got is that what happens at the end of March 22 currently, I guess.
Thank you, Andrew. And I think a lot of people have that. It clearly needs to be part of a future plan, as something that we think about. But I think probably in the short term, if we convert and make the recommendation either yea or nay for the preferred option, which is 3, with a mind to thinking, like I said, about so many other things, but at this current time, about this particular issue, which is the laptops, which we know have been invaluable. Andrew shared, and some of our governing body members who were GPs have also shared that they've been invaluable and taken some of that pressure off to enable them to get the work-life balance, and when they've been isolating too. So if I can have a show of hands and nod if we're in agreement.
Well, I think I'd just note for the minutes, Julie, that what we're agreeing to is to continue to fund into next year, because we haven't got an opportunity to do anything else.
Yes.
But I don't think we can commit to undertake or underwrite for primary care that decision will continue in perpetuity.
Absolutely not, Simon. And I think, as I said, in a lot of issues that is going to be the case. But you just hope that we can resolve other other things in the future as amicably. Yeah, and Simon's there's a message to Simon in the chat box. Andrew thinks it's very fair, and it is, yeah. So thank you all. Again, another valuable discussion, and thank you, Sean, for the work that's gone into that. Thank you, Andrew, for leading your meeting and coming and joining us again, and everybody else that's juggling. Right, I've hidden my menu. I'm thinking about food. You can tell I'm hungry and haven't eaten lunch yet. It's over to you now, David, please. If you can take the floor.
Yeah, hi everyone. I have been here during the meeting, but I'm on all sorts of IT problems, so I've kept my camera off. It's Zoom. I've got to do it through the browser, and it doesn't seem to be able to cope very well. So I just wanted to sort of say just from an NHS England point of view on the Hemingway branch closure, all we'd ask from NHS England is the patient impact is considered, which has been done, and that generally as a CCG you'd consider the estates being suitable to deliver primary care, and you've taken that into consideration. So I just wanted to note that, I didn't have an opportunity earlier. Okay. So a couple of things we're asking the committee for a decision for. So the first one is Sherburn Group Practice. They're in the final stages of developing and submitting a project initiation document to secure NHS England capital to extend their practice premises. Development is much needed due to the significant population growth in the area, as well as the need to provide clinical space for the PCN additional roles. The project is quite a large one. It's estimated to cost £2.1 million, funded through a combination of NHS England capital, council funding and practice contribution. The district valuer has assessed the plans and estimated the notional rent would increase from circa £57,500 per annum to £121,800 per annum. However, taking into account the capital funding, there would be an abatement, which would see the notional rent set at nearer £85,800 per annum for the 15-year abatement period. And it's worth noting that once the council funding is factored in, we'd expect there would actually be a bigger abatement, as we'd expect the capital and council contribution to be more than 66%. A new build proposal couldn't be taken forward, so this is currently deemed to be the only viable estate solution to meet primary care needs of the patients in this area. Obviously, we would have liked to have brought the PID through for formal approval, and that's in the final stages of being developed. But probably there's speed is a bit of the essence to secure the funding within this, to start the programme within this financial year, because some of the capital is there for this financial year. So we didn't want to leave the approval in principle for the scheme and an acknowledgement of the revenue impact until January's meeting. We needed to sort of have the ability to progress it before that. So I think the request of the committee is really to support the scheme in principle, and I think we'll probably look to then bring the PID through for approval in between this and the next meeting, but we can bring it for ratification at the next meeting. So it's probably just need to understand if we've got support for that. Or any comments? Great.
Sorry, we've got a question from Simon, please.
That's not a question, it was a thumbs up.
Oh, was it? Sorry. This may be really negligent. Thumbs up, yes. We've got approval on that, thank you. It makes sense.
I'll bring an update to the next meeting regarding that. Second one.
David, before we move on, can I just thank the committee? Because if you remember, this is a scheme that the practice have been working on, well, 5 years, and it's gone through multiple iterations. So we're really close to being able to deliver them the component parts with our stakeholder partners, the council. So this is just a reflection of how long estates schemes take to arrive at. So I really appreciate you supporting something in lieu of seeing the details in the PID. Thank you.
Thank you, Steph. That's really. I've been involved before in some estates changes, and I am aware of how long it takes, and it's hard slog, and it's U-turns and dead ends all the way, which it probably has been here. When you mention the new build, that just, I understand where you're coming from. So thank you for that. Would you like to move on to the next item, David?
Yeah, thanks. So the second one, Front Street Surgery have a branch site in Cotmanthorpe Shopping Centre. The lease expires on Christmas Eve. They've agreed a 5-year extension with the landlord under the same terms and conditions of the existing lease, with the exception of a slight increase in rent. So we will ask the DV to assess the rent. However, we noted that it hasn't increased since the initial lease was put in place 10 years ago. So we fully anticipate that the proposed rent in the lease will be in line with current market rental value. And if you have a sort of slight feeling of deja vu, it's because this came to the group quite recently for a very short-term extension. So this is just securing a longer-term provision. So again, just looking for committee support with that.
So, sorry, I'm just wanting us to reflect on the conversation we had about Hemborough. So, Dave, you and I can have a conversation offline about a site visit and its fit for purpose nature before we sign a contract to a 5-year lease. We give an approval for a 5-year lease because it is a branch site to the main site. I think we need to offer a level of consistency.
Thank you, Steph. Yeah, that's invaluable. So I think what we're saying here is we're not recommending it yet. We've got some more work to do and then we'll come back. Okay. Thank you, Steph. Thank you, David. So if we move on to your next item, please.
Yeah. So so this is so Priory Medical Group formally asked to extend their practice boundary earlier in the year, and if you remember, this was following a review. The practice found that after the Abbey Medical Group merger with Priory Medical Group in 2012, the boundary appeared to have reduced in size. And whereas it had initially included all of Stockton in the Forest, it now seemed to only include half of the village. I've included the report that was presented to the committee earlier in the year within this this month's papers, which is showing the proposed boundary. And there's approximately 200 patients registered with Priory who are outside of the current boundary. So when it went out for consultation, Haxby Group Practice had raised some objection to the proposed boundary extension. Following discussion, the committee felt unable to make a decision. So we said we just needed some further clarity from Priory Medical Group as to understand the impact of this proposal and the patient benefits and to understand any potential risks. So I did follow up with Priory Medical Group. Following those discussions, so firstly to reiterate, this is seen by Priory Medical Group as correcting what appears to have been an error or an oversight in determining the practice boundary when the practice merged. It came to light during a practice cleansing exercise in which they were looking to actually reduce their patient list to create better access rather than expand, and that's when they became aware of the anomaly. So rather than removing the patients or treating them as out-of-area patients, the practice felt it was best to formally amend the boundary to include all of Stockton in the Forest and avoid any confusion moving forward. Priory Medical Group did say, if it was approved, they'd have no intention of publicising the decision or trying to attract new patients. And therefore do not anticipate any patients moving practice as a result. The main benefit to the 200 patients in question would that they'd be able to remain at Priory Medical Group practice, which would offer a continuity of service to them or without the risk of them being removed in the future. But Priory Medical Group did acknowledge, and they were very open about it, saying that they didn't have any intention to remove these patients or amend the existing service they offer to them. So they'll continue to treat them as they would any other patients, but they just felt they were keen to clarify that the practice boundary and basically potential confusion in the future if another list cleansing exercise was undertaken. I didn't want to sort of shoehorn patient benefits in there around more patient choice and things like that, because I don't think this is actually what this was about. I suppose on the flip side, appreciate it was pre Vale of York CCG, and it would have been pre NHS England days when I think the merger first went through. But if the merger of Abbey Medical Group had gone through and they proposed to reduce their practice boundary, I imagine it would have been rejected. So it does appear to be correcting a historic anomaly, which shouldn't be setting a precedent and shouldn't offer too much risk to the practice expanding. There are other practice options in the area, so any patients that are currently, say, dissatisfied with their existing practice would already have another choice as well as Priory. So we really, at this point, can't see how it would specifically impact the moving of patients, but it would offer more clarity for these 200 patients. And I think for the patients of Stockton on the Forest, they'd all have, rather than it being arbitrary, sort of half the village having access to the opportunity to register a Priory and half not. It would be more clear and more consistent. So they were the discussions I brought back. Obviously, welcome any more questions or any more points of clarification. I'd be happy to take those away if we still felt we weren't in a position to make a decision.
Thank you, David. Any more questions or comments?
Right, fine.
No. No. Thank you, David. I do recall this, and I think we did ask numerous questions, and thinking about the sort of the process of questions that we asked, and that you have answered them for us fully. And I think
it was very handy, Julie, being able to watch the recording back to clarify what questions were.
It does help sometimes. Well, people will see me scribbling away, and I do try and write notes. But I always, if I can, I mean, I've got the opportunity to look back, I will, and then I will idiot-proof them by whoever it was that spoke. I'll just say, can you just run? Can I just run this by you? And the experts step up and help me. But thank you. It was invaluable to hear. And to read that that process had been given the due care that we asked for. So it remains for us to vote for this one, a recommendation. Yeah.
Great. Thank you.
Okay, thank you. Lovely.
Just a few more points for noting, which I'll whiz through quite quickly. First one's been touched on, that systems had to submit plans by the 28th of October to secure support from the Winter Access Fund, which has been introduced to increase access and resilience in primary care through winter. The plans, the Humber Coast and Vale plans, which include system-wide support as well as tailored support for individual practices, have since been approved by NHS England. Regarding the delegation of primary care, plans have been submitted by Humber Coast and Vale as to how the delegation of primary care will be undertaken from April 22. The proposal, which was accepted by NHS England, was for primary medical care to be delegated from April 22, as it currently is, and for community pharmacy, dental services and optometry services to be delegated from April 23, but in shadow form from October 22. Third point is the general practice electronic declaration is open for practices to complete, which allows them to self-declare contractual compliance, and the deadline for that is tomorrow. And finally, that a digital primary care flexible staff pool has been commissioned in Humber Coast and Vale using system development funding. A 2-year contract has been agreed with a supplier called Lantern, and practices are being made aware with the details of this offer and how to register if they're interested. That's everything. Thank you. I think my IT survived, which is a miracle.
Any more questions or comments to David? That's brilliant. Thank you all so much. So looking at my scribble, I'll bring some messages, some key messages to governing body. And our next meeting is 1:30, the 27th of January. So should I wish everybody Merry Christmas, or is it too early? Never too early, maybe. Anyway, thank you everyone for this afternoon. I think it's been a very, very valuable discussion, and just to reassure people that the pre-discussions were lengthy and valuable, and our colleagues worked really hard to bring the reports to us that we needed to make an informed choice on your behalf. So take care, everyone. See you all soon. Thank you all for joining us. Apologies for the gremlins in our technology, but I think we've got there. I'm going for chocolate now. Thank you.